Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hello, everyone, and welcome to Attitude Magazine's ADHD Experts broadcast. We are very pleased to have Dr. Russell Barkley here, who will be talking about the key issues for adults diagnosed with ADHD. Before we get started, let me note a couple of housekeeping items. Those of you tuned into the live webinar may download the slides now by clicking on the Event Resources section of your webinar screen. And if you are interested in the Certificate of Attendance option, look for instructions in the email you'll receive about an hour after the live broadcast. For those of you listening in replay or podcast mode, please visit the webinar replay page on the Attitude website. That is www.attitudemag.com/podcast-323/ for access to both the accompanying slides and the Certificate of Attendance option. Now for today's topic. ADHD in adults is among the most impairing outpatient disorders seen in clinical practice. ADHD is viewed as a disorder of self-regulation and executive functioning. The condition has an adverse effect on family functioning, self-care and independence, education, peer relationships, sexual activities, driving, money management, occupational functioning, antisocial behavior, substance abuse, marriage, and child rearing, among others. As you can see, it affects every facet of one's life. ADHD expert Russell Barkley will discuss the latest research on how to meet all of these challenges. Dr. Barkley is a clinical professor of psychiatry at the Virginia Commonwealth University Medical Center in Richmond, Virginia. He is a clinical scientist, educator, and practitioner who has published 26 other books, rating scales, and clinical manuals numbering more than 43 editions. He's also creator of 7 award-winning professional videos. You can ask questions of Dr. Barkley during his presentation, and we will try to get to as many of them as we can after he finishes. That all being said, I'll turn it over to Dr. Barkley. Thanks so much for being here.
Thank you so much, Wayne. I really appreciate the opportunity to speak with everyone in attendance today about the key concerns that we have about the diagnosis and management of ADHD and also strategies for dealing with some of these concerns. I'm going to begin with just by a quick review of the DSM-5 criteria, which I assume all of you or many of you are quite familiar with, so there's no need for me to spend much time on them, except I want to talk about all of the changes that have to be made to these criteria when we apply them to special populations like adults with ADHD, people over the age of 18, for instance. So you're all familiar with the DSM criteria. We have a neurodevelopmental disorder that consists of 2 dimensions of neuropsychological traits that are not developing on time or functioning effectively in people with this condition. One of the dimensions is often called inattention, and there are 9 symptoms of that, and all of them are qualified by the word often, and you have to have at least 5 of those 9 symptoms occurring often to meet the first of the diagnostic criteria for a possible diagnosis of ADHD. So that's all well and good. The second dimension or trait that is failing to develop properly is that of hyperactive impulsive symptoms, which we abbreviate to disinhibition. There's a problem with behavioral and motor inhibition here, and it is manifested by the 9 symptoms that you see here, again, all qualified with the word often in front of them. And again, to be diagnosed with ADHD, the first criteria you have to have is at least 5 of the symptoms on this list. So as you know, it's 5 symptoms on either of the 2 lists. And the symptoms, again, occur often. By the way, in case you are wondering, that word often is not simply pulled out of thin air. It's not arbitrary. Research shows, as my own research has in developing rating scales, for instance, that that word is rarely used by adults to describe their own behavior or used by parents to describe the behavior of their child. So while many people might show a few of these symptoms occasionally, some of the time, that doesn't qualify as a symptom. To be a symptom, it must be occurring frequently. And that's what that word often means. So only about between 2 and 10% of the population would ever endorse the symptom as occurring often. And if you require 5 of those, as we do, you have winnowed the eligible population for ADHD down considerably, down to, in fact, about 5 to 7% of adults would endorse 5 of these often symptoms on either list. So I find for clinicians and even for patients, it's very helpful for them to understand that we're not just diagnosing typical, everyday, ordinary behavior that we might see occasionally in a typical individual and turning it around and calling it a psychiatric disorder, as critics of ADHD like to state, because they're basically ignoring the way we really do diagnosis of this condition. Now, in addition, there are additional criteria that have to be met. Not only are the symptoms occurring often and developmentally appropriate, and you have to have at least 5, then beyond that, there is the requirement of a childhood onset for the symptoms. And right now, the DSM-5 has age 12. It used to be age 7. As I will say in a moment, there should be no age here at all. But there is this age of onset requirement. I have 2 comments about how we need to modify these first 2 criteria in order to make them more appropriate for adults. First of all, the DSM symptoms were developed on children and for children. That's their history. So going back to DSM-3 and 3R and even 4, all the field trials were done with children. So the phrasing of the items is intended for children. And therefore, when we try to extrapolate the use of these items into clinical practice with adults, some of them don't work well, such as can't play quietly or driven by a motor. Those are not the kinds of things that adults would necessarily endorse. And we had given the DSM-5 committee a variety of new symptoms that were better than the DSM at detecting the adult level of the disorder, but the upper-level DSM committees did not allow the ADHD committee to include them, and therefore they didn't get in. So we're stuck with using children's symptoms that we have to torture in a way to make them applicable to adults. What they did allow the ADHD committee to do in the DSM is to create clarifications of a symptom and put them in parentheses after the symptom. And those clarifications are for teens and for adults. And that's very nice. The problem was it was done at the last minute. There was no effort to actually empirically test any of these phrases that were being invented in a committee conference room whole cloth without regard for whether they really were clarifications of that symptom or were even related to that symptom, or whether they were indeed becoming new symptoms in the list. And so they weren't tested. And that's a big problem when you're trying to invent criteria for a disorder. And indeed, Dr. Laura Naus here at the University of Richmond and I completed a study earlier in the year that we presented in January at a scientific meeting in which we did go out and look at how well those clarifications pertain to their original root symptom. And the results were sobering and rather poor. Indeed, although many of the symptoms continued to be related to ADHD more than to anxiety and depression, a few of the symptoms were actually more related to anxiety, such as distracted by internal thoughts and preoccupations. That became a very poor symptom. Also, we found that the correlation between the clarification and the root symptom was very low, often 0.3 to 0.5 or less, which is not good. It suggests that the clarification really isn't reflective of the symptom, but is now yet another new symptom of adult ADHD. And that is going to cause problems because when you're adding on all these extra symptoms, but you're not adjusting for the symptom threshold of 5, it's supposed to be 5 out of 9, not 5 out of 15. And yet that's what it's becoming. And so we did notice that there was a rise in the number of people who might get the diagnosis of ADHD by using those clarifications. They basically were behaving as yet more symptoms added to the 18 symptom list. So we need a lot more research on that issue. Until then, my advice, friends, is ignore them. Continue to use the original symptoms as we always have with adults with ADHD. If they want a little clarification, you can perhaps elaborate, but I would not get off into these clarifications too much because it looks like they're not working very well. Again, a clarification as well for me, or a modification that is look at that childhood onset of age 12. Now, nature does not respect a number like this. The onset of ADHD in people's lives occurs at any point in time. Usually, in 93 to 98% of the cases, it's before age 18 to 21 years of age. And that will capture just about everybody. Children, teens, even adults with ADHD often report the onset of their symptoms before age 18 to 21. There's still a small percent who don't, and you can have acquired ADHD. Let's say that you're an extreme sports athlete who skateboards a lot, has a lot of head trauma, and you're a young adult. You get enough TBIs, and you can develop a form of ADHD secondary to TBI. So we need to allow for the onset of acquired ADHD cases at any point in life and understand that these could be taking place even in childhood or adolescence. So don't get all caught up in a number, 12, 7, 16. It's onset during development. That's what we're looking for. And that's good enough to identify legitimate cases of ADHD who otherwise will meet all the other criteria, but might not meet that one. Another point I want to make about that criterion is that the adults with ADHD, like parents of ADHD children, are terrible at recalling the age of onset of their symptoms. Absolutely abysmal. And we studied this in my longitudinal research where we documented the onset of the disorder in childhood. We then saw these people every 5 years. And at age 27, we interviewed them again about their symptoms. We interviewed their parents about their symptoms. We ask again, when did your disorder start? And comparing those results to what we had 20 years earlier in childhood was frightening because they were off by 3 to 5 years in their estimate, often reporting it far later than it actually was documented in the charts back when they were children. So, you can ask an adult with ADHD, when do you think your symptoms began? They can tell you when it was, add 3 to 5 or subtract 3 to 5 years from that. And that's when the symptoms really did begin to occur. So this whole issue of age of onset is a tempest in a teapot. It needs to get thrown out. Onset during development, as best as the individual can recall, good enough. It's not really a symptom we want to, hang our hat on for diagnostic purposes. And of course, the rest of the criteria. The symptoms have to occur in several different situations. There has to be significant impairment. No impairment, no disorder. I don't care how many symptoms of ADHD you tell me you have. If by history we can't find any evidence that you have experienced impairment, except perhaps taking a high-stakes multiple-choice test to get into law school or medical school, you don't have ADHD. Taking high-stakes exams to get into university is not a major life activity, and that will not qualify as impairment. We're looking for domains: occupation, education, financial, driving, marriage, cohabiting, raising children, and so on, your health and well-being, substance use, criminality. These are major domains of life. And we want to see at least one or more of them reflective of impairment, that you're having trouble functioning, and it shows. Now, how much impairment, how much ineffective functioning is enough? And the threshold for that is when the environment kicks back. That is when we start to see negative or adverse consequences occurring because of your behavior. So were you retained in grade? Were you kicked out of school? Did you get special education? Did you lose your driver's license? Have you had difficulties with promotion relative to your career path and your IQ and so on? We want to see that there have been adverse consequences, the environment kicking back for there to be impairment. Now, the DSM, which I think is laudable, now requires corroboration of self-reports through another source. And that's very important because ADHD adversely affects self-awareness, and that leads to people underreporting their symptoms and impairment, and therefore we want to check it out against the reports of someone who knows you well, parents, siblings, partners, somebody who really has spent a lot of time with you. We also want to check it out against your archival reports, your educational record, your work record, your driving record, perhaps your criminal record. Are any of these reflective of symptoms and impairment? And so we want to make sure you're impaired, and we want to corroborate it through other people. And then, of course, the rest of it you already know. We exclude other disorders that might explain the symptoms. Inattention is seen in virtually every psychiatric disorder. So for somebody to say that they're experiencing problems paying attention is of no diagnostic help. We want to know the kind of inattentiveness, where it shows up, and so on. ADHD is very much a disorder of persistence toward goals, the inability to sustain action toward goals, assignments, tasks, toward the future in general. That's a very special kind of attention granted to us by our frontal lobe, and that is what people with ADHD struggle with, along with, of course, being distracted by goal-irrelevant events around them when they're pursuing a goal. So it's goal-directed action and persistence that we're looking for beyond just being inattentive, because anxiety disorders produce inattention. Depression certainly does, as do other disorders. So make sure that when you rule out another disorder, you're ruling it out as an explanation for the problem with persistence toward work, toward goals, toward tasks, toward future events. I can't sustain action over time. I can't resist distractions that surround me, and this has been a chronic problem for me dating back to childhood or adolescence. Now, you know that the DSM-5 got rid of subtyping. Hallelujah. There are no subtypes of ADHD. There never were. All the differences we found between the earlier subtyping were simply reflective of the fact that some people were more inattentive and some people were more hyperactive, but there was nothing meaningful in those subtypes, nor were they qualitatively different. Indeed, it was very common for children to go through all subtypes in growing up with ADHD. So now they're just presentations. They're simply meant to reflect the relative degree of severity of the two symptom lists at this point in time. And they are meant to convey nothing else besides that. They're just a descriptor. So that said, let's get rid of this idea that there are kinds of ADHD, types of ADHD, and also that there's some peculiar adult onset form of ADHD. Because as I said, even those papers turned out to be flawed because they didn't take into account that self-reportive age of onset is horrible and unreliable. And when you take that into account, then you're not really studying anything of significance there. Now, that's how the DSM looks at ADHD, and those are the kinds of adjustments we need to make to our criteria, understanding as well that ADHD interferes with more than just attention and inhibition. It interferes with the whole fleet or swath of executive functions that go along with ADHD and are part of our frontal lobe executive network. And you can see that now when I describe for you adult ADHD. As a clinical researcher, looks for it and listens for it in interviews with patients and looking at other methods like rating scales and corroboration with others. What are we looking for? Well, we're looking for The problems with what we call executive functioning, that's what the inattention symptom list reflects. And these are known as metacognitive functions. And what are they? I've listed them already. Persistence over time toward goals, tasks, and the future in general. The person with ADHD is time blind. They can't deal with future events, with impending deadlines, with things that are coming at them. They leave everything to the last minute because they're not preparing for events over time. They also can't string actions together to complete lengthy assignments that involve time and so on. So persistence is deficient. Coupled with that, less able to restrict responding to distractions around them that are goal irrelevant. They have nothing to do with the task or the goal that you're pursuing. Now, oftentimes we will all be distracted from a goal that we're pursuing. We have to deal with that, and then what do? We go back to the task that wasn't finished. Task re-engagement following a distraction is not a function of attention. It's working memory. The frontal lobe grants us the power to hold in mind information actively, consciously, that we are using to direct our behavior over time. And that is what working memory is. It's remembering to do goals, steps, and progress, and keeping that in mind. It's what you lose after about 55 to 60. It's what I've been losing for over a decade now. And that is, I can't hold in mind my intentions, what my goals are. I could go out to the mailbox to get the mail and find that I'm pulling weeds, reading the paper on my sidewalk, taking the trash can back behind the garage, chatting it up with a neighbor I see on the sidewalk, and I never got the mail. So that's working memory. Having ADHD is a lot like being old times 10. Your working memory is shot, and you can't keep in mind what you're doing. And when a distraction occurs, it shatters your working memory, and therefore you can't re-engage the incompleted goal following a distraction because it's not there anymore. You're now skipping from one thing to another, with the now leading you along by the nose. Wherever the now is going, that's where they go. That's what I'm listening for. Okay, and that's impaired working memory. And the forgetfulness item in the DSM sort of reflects that. So what are we seeing? We're seeing problems with persistence, resistance to distraction to external events, failure to re-engage tasks following distraction, and in general, difficulties holding information in mind that is supposed to be needed to guide us over time. That's the attention problem that ADHD is producing. And when we listen for the inhibition dimension, we are listening for impulsivity that cuts across a variety of brain functions and modalities. Excuse me. First, there's the motor inhibition. In children, of course, that's the hyperactivity, but that declines markedly with age, so that by adulthood, it's more reflected in seat restlessness and in an internal subjective feeling of being restless and needing to be busy. But adults aren't climbing on furniture, sliding down banisters, tearing around classrooms the way hyperactive children are likely to do. So my advice to you is don't weight the motor impulsivity quite so heavily with adults. We found it was of no value in separating adults with ADHD from other disorders. So hyperactivity is not a big deal anymore. The second form of impulsivity reflected in the DSM is verbal, talking too much, failure to inhibit. So you're interrupting others, you're answering questions before they're done, you're intrusive. So there's a verbal impulsivity, which by adulthood, by the way, actually begins to separate and become its own little factor from the motor activity that is so impulsive. Probably because the motor activity is developmentally declining and more characteristic of young children, whereas the verbal impulsivity is gaining with time, so to speak, and becomes more differentiating of the adult with ADHD. But now come three kinds of impulsivity that we see that aren't mentioned in the DSM at all. We tried to get them in when DSM-5 was being modified, but didn't happen. They got thrown out by the upper level committees, and they're not there. But clinically, they're there, and you need to listen for them. There's a cognitive impulsivity. The individual is making very quick decisions without regard to contemplation, thinking ahead, and appropriate review of that decision. So there's very little restraint here. It's almost like the brain is on automatic pilot and behavior is being up, out, done, without regard for truly thinking through what you are doing. So there is a poor contemplation coupled with a rapid decision-making that is going to be the bane of this person's existence. And that is seen in thinking and decision-making. Then there's a motivational impulsiveness where the individual is opting to do whatever they can to get small rewards now, whatever's interesting, whatever's fun, whatever's rewarding, whatever's happening, and is unable to work for larger but later delayed rewards. It's called a high time preference in economics. It's known as reward discounting in behaviorism, but it simply means that the further away from the task the reward or the consequence occurs, the less motivating it is. And the individual can't generate the motivation to complete the task in that case because they don't value the delayed reward over the immediate reward. So there's a motivational impulsivity that is very characteristic of these people, which is why they find it hard to complete lengthy assignments that may be relatively boring but are crucial to finishing a college class or getting your degree or completing a project for an employer, and they just procrastinate and can't seem to get around because everything else around them is more interesting, that offers rewards for engaging in it than does the task at hand. And then there is an emotional impulsivity, very, very central to ADHD. And by this, I mean impulsive emotion. Not weird emotion, not irrational emotion, impulsive. So the individual's emotions are provoked very quickly, very strongly, but they're understandable. They're typical emotions, but other people of this age wouldn't have shown them, would have moderated, suppressed them, bit their tongue, count to 10, gone to their happy place, and calmed down and self-soothed rather than display the emotion so impulsively. So there's an immaturity in the inhibition of emotion that characterizes ADHD and separates it from a mood disorder like disruptive mood dysregulation or bipolar disorder. Those are moods. So ADHD individuals show impulsive emotion, and once provoked and displayed, difficulties down-regulating it, grappling with it as quickly as other people are able to do. And this is important, even if it's not in the DSM, because it's predictive of many of the areas of impairment they're going to experience, from the number of jobs they've been fired in, to how much they engage in road rage, to intimate partner violence, to satisfaction in marriage and cohabiting, to impulse buying. All of these have to do with the emotional impulsivity of ADHD that can't be accounted for by the more traditional symptom list. So now, as a researcher, I've explained to you what we see in our research findings. That's what I want people listening for in the clinical exam and diagnosis of ADHD. Because, by the way, I've just listed 6 of the 7 executive functions, and they are limited self-awareness, impaired inhibition, poor verbal working memory, especially poor visual or nonverbal working memory, poor self-motivation, deficient emotional self-regulation. The only one I didn't mention was planning and problem solving, and that's problematic as well. So all 7 of the executive functions are known to be deficient to varying degrees in adults with ADHD. So keep in mind then, in using the DSM-5 with adults, there's more than inattention going on here. There's impaired executive functioning, impaired working memory. There's too many symptoms of hyperactivity for adults. Don't pay attention to them. We need to pay more attention to the cross-modal impulsivity I've just described for you in thinking, in emotion, in motivation, and in language and verbal behavior. And then, of course, we need to make sure that we are using developmentally appropriate symptoms for adults. And if you'd like, I have a slide of those that I would be happy to send to you that work very well. And then we want to make sure that the cutoff, the age of onset, as well as the threshold for symptoms is not being adhered to dogmatically and religiously. I told you age 12 doesn't matter. Onset during development is good enough unless there's a clear-cut neurological event after which the disorder developed, and then it can develop at any age. And then, of course, we want to make sure that instead of using 5 symptoms as the DSM recommends, all of the research that has been done, my work, Steve Ferrone, Joe Biederman, and Jan Budelar in Holland and others, shows that the magic number is 4. 4 symptoms of ADHD is sufficient to make you developmentally inappropriate, not just 5. So if you hit 4, that's good enough for diagnosis. Remember that the cutoffs are based more on boys than girls because there are more boys in the field trial. So you always want to be using rating scales that compare girls to girls and boys to boys, or in the case of adults, men and women to their respective sexes when we evaluate the scores on the rating scale. And then, as I've said, the age of onset is problematic. So, okay. Now, another way of thinking about adult ADHD I find helpful clinically is to keep in mind that executive functioning is not about knowing things. It's about using what you know for effective performance in life, for social, occupational, educational effectiveness. So the back part of your brain, as you see here, is the knowledge brain. That's where we learn stuff and we store it, okay? No big deal. ADHD does not involve that part of the brain for the most part, all right? And that's not executive functioning either. But the front part of the brain is where we take what we know, activate it, hold it in mind, and use it to guide behavior and performance. It's where we show what we know. So ADHD, in a sense, functionally disconnects these 2 pieces of the brain, so to speak, these 2 simplistic systems, so that knowledge isn't guiding performance. What you know is not coming forth to be held in mind to do what you know already you need to do. There are some implications of this. Number 1, people with ADHD are as smart and knowledgeable as anybody else. They're not stupid. So the idea that ADHD arises from simply not knowing how to behave, not knowing time management, not knowing how to organize ourselves, for instance, not knowing how to inhibit, that's just foolishness, right? So people with ADHD don't have a knowledge deficit. What they have is a performance deficit. They can't use what they know. So the implication of that then is that when we're working with them clinically, we're not going to spend a lot of time going over knowledge. Here's how to manage time. Here's how to do this, and give them all these little lists of things that they need to do. They're not going to do them. They're going to tell you how great they are. They're going to tell you this is what I need to be doing, and then it's going to be ignored under the car seat. The dog's going to eat it. It's not going to matter because the problem was never knowledge to begin with, right? It's using what you know. And to do that, all treatment has to be at that point of performance, change that point of performance, add in the structure, the scaffolding, change the accommodations, change the expectations, and then the person performs what they know. That's what we need to do. So addressing ADHD, unlike a learning disability or autism or intellectual disability, is not about teaching skills, knowledge, and how to do stuff. It's about getting them to use that stuff out there where it matters. That's the hard part. That's why ADHD is so difficult sometimes to deal with, because it doesn't involve knowing. And it's what really ticks people off about adults with ADHD. How come you know how to do this, but you don't do it, right? I don't see it in your everyday performance. And then we start getting into moral interpretations of behavior. You're just a layabout, lazy ne'er-do-well. The adult with ADHD buys into that. So we see demoralization, dysthymia. I'm a failure. I have no willpower. And, everybody's interpreting this as a willful choice, when in fact, it's a classic illustration of an executive failure. The knowledge doesn't control the behavior. So keep that in mind when you think about ADHD clinically and when you're evaluating people, or if you're an adult with ADHD listening to this, because that's the heart of the matter to me, right? It's a performance disorder, not a knowledge or skill disorder. And the best ADHD coaches, as well as the best therapists like Mary Salanto, who's developed her own executive functioning training program, and Russ Ramsey at UPenn, who has his as well, they all focus on that issue. And that is changing points of performance to help you show what you know, to perform effectively. Now, we know that over time, as kids move into adolescence and adulthood, there's a variety of impairments that rack up with ADHD, and we could spend hours on each of these in great detail. But I just want to illustrate them, that as we move into adulthood, we've already seen problems with education, limited educational success, reports of family conflicts when I was growing up, lots of arguing and commands and punitive behavior and difficulties making and sustaining friendships, and often feeling rejected by friends, including when we are dating other people. We're going to hear complaints in about 40% of people of increased antisocial behavior, of lying, of stealing, of reactive aggression, and so on. And of course, adults with ADHD often look back and talk about their adolescent and adult years with excess use of substances, particularly nicotine, alcohol, and marijuana are the most commonly used to excess, if not abused to the point of a formal substance use disorder diagnosis. We often see a pattern of risky sex, starting sexual activity earlier, having more partners, but less time with each partner because the relationships would burn out, of not using contraception. So 40% of ADHD children, as a father or a mother, will have been involved in a pregnancy and even a birth of a child at a very young age, below 19 years of age, as well as increased risk for sexually transmitted disease. Accidental injuries are 2 to 3 times more likely in people with ADHD across the lifespan, leading to a marked increase in early mortality. Children are twice as likely to die by age 10 from accidents. ADHD adults are 5 times more likely to die by age 46 than others, so that this is a cross the lifespan risk for them. And then, of course, as they get older, the risk of suicide attempts becomes problematic too. And then driving. Oh my God, driving is so bad that it actually could be an official symptom for adult ADHD, and that is excessive speeding with a motor vehicle, leading, of course, to increased crash risk, increased citations and speeding citations in particular, and so on. So now they're entering adulthood, and we should be hearing occupational difficulties, trouble working independently of supervision, changing jobs impulsively, being fired more often, and of course not earning as much as other people of the same status and education and time in the workplace. And this leads to financial difficulties, excess use of credit, failure to repay loans, utilities being turned off, credit ratings that are lower than typical. Those are the kinds of outcomes or consequences we start to hear. I've already mentioned the health risks that link up with ADHD, specifically twice the rate of obesity, increased risk of coronary heart disease. We've talked about accidental injury already, suicide. Women have an increased risk of bulimia or binge eating disorder because of their disinhibition around food. Of course, more sedentary activity, less exercise, poorer overall health by adulthood. This has become a very big area of concern now, suggesting that adult ADHD is a public health disorder, not just a mental health disorder. And then, as I've already mentioned, problems with cohabiting with others, with intimate partner relations, and even an increased risk for intimate partner violence. So now, all people with ADHD don't experience all of these difficulties, of course not, but they are more likely than typical people to experience them, and may experience them more often than other people do. So again, we're listening not just for symptoms, but the consequences of those symptoms as they play out in life. This slide should illustrate for you why we know ADHD is among the most impairing outpatient disorders that we have to deal with. Depression does not create that swath of multiple impairments across multiple domains to that degree that we see. Neither does anxiety, neither does learning disorders, and so on. So the kinds of disorders we might commonly see in an outpatient clinic, ADHD is one of the most problematic in terms of impairment. Now, over 80% of adults with ADHD are going to have a second disorder, over 50% of a third disorder, so comorbidity is very high in adult ADHD. I want to thank Sandra Cooey, my good friend in Holland, for letting me use this slide illustrating the comorbid disorders that go with ADHD. And time doesn't allow us to go through them, but you can see that, of course, there are those related to impulsive and disruptive behavior, such as oppositional behavior, conduct problems, antisocial behavior, antisocial personality, borderline personality, and so on. And then we have anxiety disorders, which, by the way, are about 15 to 20% in children, but more than double by adulthood. Research shows the longer adult ADHD goes untreated, the greater the likelihood an anxiety disorder is going to be coexisting with it. Social anxiety being the most common, but of course that's the most common anyway in adults, and then generalized anxiety. We have problems with sleeping occurring in about 40% of our adults, just like we saw in children. This can be obstructed sleep, restless leg syndrome, frequent waking, early rising, generally leading to inefficient sleep and daytime tiredness. Learning disabilities occur in 35 to 50% of adults with ADHD, which is why they have to be screened for in the evaluation of ADHD. Those are separate disorders. They're not the result of the ADHD. They're independent of it. It's not to say that ADHD doesn't interfere with schooling. It certainly does, and with comprehension, and with motor coordination and handwriting and productivity and so on. But it's not creating a reading disability or a math disability or a spelling disability the way that the specific LDs are known to do. Substance use disorders I've already mentioned as being problematic, becoming more so by young adulthood than even by adolescence. And then, of course, about a 25% risk for dysthymia or major depression, much lower risk for bipolar disorder being about 4 to 8%, still higher than typical, but not much higher than we would see in the general population of about 2% as well. So a big array here of psychopathology, of comorbid disorders occurring in adults with ADHD. Now, why is that important? Because you're going to have to treat that comorbid disorder in addition to whatever the treatments we are going to use with the adult with ADHD. So it complicates matters. And in some cases, the second disorder may actually affect decision-making about treating the ADHD. For instance, as with an anxiety disorder, one might find that one might want to use a non-stimulant before a stimulant if there's a major anxiety disorder present with the ADHD. If there's major depression, we would want to treat the more impairing of the two disorders first and then return back to treat the less impairing of the disorders. That's just an example of how comorbidity might affect decision-making around treatment. Now, when it comes to treatment, there are 5 components that we look for in an optimal treatment program. The first, of course, is the diagnosis. And then following the diagnosis is educating the patient about the nature of ADHD, that it's a broader problem with executive functioning than just ADHD, that it in fact is a highly impairing disorder that could even be life-threatening if it's not properly treated and consistently treated. So we want to go into the nature, the causes, the course, the risks for ADHD as part of the counseling and initial education about the disorder. Following that, in my opinion, 70 to 80% or more of adults with ADHD are going to need to go on medication, either stimulant or non-stimulant, if they have at least moderate to severe ADHD and experience impairment. Then medication is going to be necessary. And the reason that we go to that so strongly as step 3 in our package is that the medications are the most effective treatment we have, bar none. So it doesn't matter whether we're going to compare it to behavioral treatments, cognitive behavioral, executive function training, coaching, and so on, mindfulness, meditation. None of them are as effective as medication. They're about 1/3 as effective in terms of degree of improvement and percentage of people who respond to them. So that is why we start with our most effective treatment first. And for most adults with ADHD, that's going to be the medication. And you all know that we, of course, have several stimulants, the methylphenidate and the amphetamine compounds. We have multiple delivery systems, from pills to pumps to pellets to patches to prodrugs to liquids to gummies to delayed onset that you take at night and activate the next morning. All kinds of new delivery systems out there to help us get these medications into the body, keep them in the body for a long enough period of time to provide coverage and effective management of the symptoms. And then, of course, we have the non-stimulants, atomoxetine, guanfacine XR, clonidine XR, that might be used instead of or in addition to the stimulant medications. So medication is usually a mainstay of our treatments with adults with ADHD because they can reach out and affect functioning in the community across a far larger part of the day and far more situations than we are able to design psychological therapies to address. Then we come to modification, and this is behavior modification, where we are trying to change the behavior of the patient in order to reduce their impairment. This is where coaching can come in. This is where cognitive behavioral therapy for executive functioning deficits comes in. There's 3 such programs that have been tested in research. Mary Solanto's book on cognitive behavior therapy for adult ADHD is very good. Russ Ramsey has his second edition out with Anthony Rothstein, also a CBT approach to adult ADHD. Earlier, Steve Safran, who no longer works in the ADHD field, developed his cognitive therapy program for adult ADHD. So they're all out there. They all have little manuals that can teach you how to implement them with adults with ADHD. So these are supplements to medication. Most of the developers require the patient to be on medication to benefit from their therapy. Mary says that sometimes she'll work with people who aren't on medication, but clearly recognizes that medication makes you available for training and for learning. And then, of course, coaching can come in here to help with ADHD, to carry out these plans and programs throughout the week through frequent contact through social media with the patient to help keep them on task, keep them on their goals, work with them if they need help with emotional control or goal setting or time management, and basically become like a proxy frontal lobe to the adult patient through the coaching system. So I certainly recommend that as well. There's some promising work going on mindfulness meditation by Lydia Zylowska at UCLA and her colleague John Mitchell at Duke. They've just published their own book on mindfulness-based methods for working with adult ADHD. I think it's going to be most useful for the emotion regulation and stress of ADHD. I can't imagine how mindfulness would benefit time management, but it is being tested now. There are promising results from the early studies. We need better studies, more rigor, but there might be something there as an adjunct to the other psychological treatments like coaching and CBT, as well as medication. And then finally, the 5th component of an optimal plan is making accommodations in the environment or the workplace for people with ADHD. And what all that simply means is we need to alter the environment, change the physical environment so the person is better able to work in that situation. For instance, breaking work down into small units, doing smaller units, take a 1-minute break, then do some more, then take a break, is an accommodation. It's not changing the disorder. It's not modifying the person. It's making it more likely that they will succeed. So we've already talked about these various treatments already. I just list them here for your own edification. In explaining ADHD, I like to talk about it as the diabetes of psychiatry, which is simply an analogy that people can remember the 5 components, that it's diagnosis, education about disorder, it's medication for the disorder, it's modifying your behavior, and then making accommodations around you. We do that for diabetes. We need to do that for adult ADHD. And then the medications I've mentioned, the counseling of the adult, getting them to own their disorder, buy into it, as Adam Levine describes in his wonderful video on YouTube that he made for one of the pharma companies. You've got to own your disorder if we're going to get you committed and being a stakeholder in the treatment plan. Otherwise, you're not going to do what we ask you to do. And then, as I mentioned, cognitive behavioral therapy, adult coaching, environmental accommodations. And then more recently to this, we would add preventive medical and dental care because of the growing awareness that ADHD is a major health problem that will shorten your life expectancy by as much as 13 years if it is not treated properly across the lifespan. Now, my executive function theory of ADHD suggests that we need to make accommodations in 6 ways at the point of performance. We deal with working memory by offloading information onto notes, cards, lists, signs, digital recorders, calendars, journals, any other storage device on which we can put information about what you've agreed to do, what the deadline is, so that you can refer to it frequently and keep yourself under control. We need an external working memory to replace the internal working memory. So externalize the information at these key points in the environment. Time needs to be made external because they're time blind. So having clocks, having timers, having the watch minder, having a digital recorder that's counting backward. You can go to Amazon and buy a 1-foot time clock with a red disc that you can set for up to an hour that shows the passage of time. The point isn't the method. It's the idea, it's the principle. They're blind to time, they can't cope with time, they need external structure to guide them through time, and we need to find ways to do that. Breaking lengthy tasks up into small units is another way of dealing with the timing problem. And then, of course, we need to help them organize their workspace, organize the flow of work, get the distractions out of the workspace, and basically do a task analysis of their workspaces, both at home and on the job, to help modify these for them. And then, of course, motivation is very weak. Self-motivation is an executive function. They find it hard to undertake tasks that don't have intrinsic appeal to them or an immediate consequence. They often procrastinate at starting the task or start it but can't finish it and are constantly drifting off task to do things that are more attractive. So we need to find ways to improve the consequences, and one of the best ways is to make yourself accountable to others for the work that you agree to do, including whether it's your coach or a colleague or an employer, a friend. You need to make yourself accountable frequently to others to increase the consequences for getting your work done. And then I like to think that we can deal with the planning and problem by helping to make it more manual, putting it in your hands. I often teach this to teachers by saying, if you're going to do arithmetic, you need to have a number line. You need to have a pile of marbles here so that the child can use their hands as part of the problem-solving process. I think that's why more adults with ADHD enter the trades than we see in other people. It's not just because they often have less education and find advanced education more challenging, but it's also because they find it more enjoyable, more interesting to be working with problems that involve their hands, whether it's carpentry or whether it's masonry work or art or performing artists or that sort of thing. Working with their hands to solve problems and invent things, they often find to be very rewarding. And then, of course, we have to help them with their emotion regulation problems, and often that includes the medications can help with that. Some mindfulness training might help with that, as John and Lydia are experimenting with, and then teaching them about situational avoidance of places where they're having problems. I want to leave you with just a list of what I think are the requirements of a job if it's going to be ADHD friendly. I've already mentioned a number of these things, so you can get the slides from the presentation and have a look at these requirements. But the sorts of ADHD friendly occupations that include those kinds of modifications you see here. And it's no surprise that we find adults with ADHD self-selecting into these kinds of occupations more than other people would, whether it's, physical education or sports, even professional sports, whether it's performing arts, whether it's sales or the culinary arts, trades, construction, or just being self-employed, owning the car wash, owning the pizza parlor, owning the landscape business. It allows you to set your own schedule, to work with your hands, to do what you love to do, and they often find that it's a lot easier to deal with their ADHD symptoms in these kinds of workplace environments. So if you're counseling adults with ADHD, particularly young adults who have yet to enter the workforce, you might be looking at the last two slides to provide your counseling advice to them. So I hope in this short seminar that you have learned about adult ADHD, that it is a disorder of executive functioning, not just attention, not just inhibition, that it cuts a wide swath through all 7 executive functions, leaving the person with difficulties with self-awareness, working memory of both types, self-motivation, emotion regulation, planning and problem solving, and so on, and that we are going to have to deal with those. So the rest of this obviously makes sense, but I do want to emphasize that ADHD is the most treatable psychiatric disorder we know of. It's a very rewarding specialty to be in because so many people respond so well to the variety of interventions that we have available. And you just don't see that in other psychiatric disorders like we see it here. Okay, we've got some time for questions, and let's see if any of them are popping up.
Yes, plenty. That was excellent, really excellent. I learned a great deal. I did. I liked the subtype discussion. I wasn't fully plugged into that. Very interesting.
Okay, thank you.
One woman is saying, I'm an adult woman and my psychiatrist dismissed an ADHD diagnosis, saying the symptoms were too mild. The more research I do, the more I believe he was mistaken. Am I wrong to continue pushing and researching and seeking a second opinion for a diagnosis?
No, you're not wrong, because I think just as parents know their kids better than doctors do, I think most of us know ourselves as well or better than the person who's only spending an hour or two with us. And it's very easy to be dismissive, I think, of these symptoms because they can occur occasionally, some of the time, in all of us. And therefore, people dismiss it. Also, I find that adult ADHD is the Rodney Dangerfield of adult psychiatry. It gets no respect because people don't understand just how serious it actually is. And that if we refer to it as self-regulation deficit disorder or executive function disorder, it might get more respect. Also, I find that the clinicians aren't probing for these additional executive deficits that are much more prominent in the adult, the time management problems, the self-motivation problems, the emotion regulation problems. They're just looking at that little simplistic child-focused DSM-5 list, which may well be minimal by the time you get to adulthood, particularly the hyperactivity. So, no, I think you need to see somebody who's going to use a more thorough interview, looking at executive functioning, using not only an adult ADHD rating scale that's DSM-5 based and has norms for women, but also an executive function rating scale that has norms for women, that is going to show how pervasive your problems are beyond this, petty little ADHD DSM-5 symptom list that some clinicians might be wedded to. So I would not take no for an answer at this point, particularly given that many adult psychiatrists are not well trained in diagnosing adult ADHD right now. And I would continue to pursue this, perhaps going to a specialty clinic or a specialist in adult ADHD who is has a lot of experience, well recognized. You can go to the APSARD.org website. APSARD is the American Professional Society for ADHD-related disorders. A lot of people are listed there, and they may be able to guide you to a clinician near you. But I would not give up.
Mm-hmm. In this era of COVID, several people have asked, is it effective to be diagnosed remotely? Can it be done?
I think it can be done. I think, first of all, let's understand that don't worry about the fact that we're not doing neuropsychological testing of executive functioning. As I wrote in an editorial a year ago, that's useless. That is of no diagnostic value. So the fact that I can't test you for executive functioning, to me, is a non-starter. I'm going to be listening for that. How are you functioning in daily life? What are your answers on these rating scales? What are other people saying about you on these rating scales? Those can all be done remotely without in-person interview. It's really the testing that gets sacrificed, but the testing wasn't important anyway, other than, perhaps a brief IQ test to rule out intellectual disability, but we're going to know that from your educational history, and brief achievement tests to rule in or out comorbidity with learning disorders, which are very common. And so that could be a bit problematic because I can't give those tests just yet. But again, your educational history is going to be indicative of the high or not high probability of whether or not you might have an LD to go with it. But the rest of the evaluation, the interview, the rating scales, the review of archival information, the corroboration through other people who know you well can be done just as well remotely.
One last quick one. Several people have asked, what about medication concerns for ADHD in people who are 50 or 60 or 70 years old?
Okay.
Is there something they should be mindful of?
Well, you should be mindful of it, of course, because there are some growing health risks that could be contraindications in the elderly population. Not being a physician, I just want to make sure you understand I'm reporting my knowledge of the literature as well as my interactions and experiences with all of my medical and psychiatric colleagues around what advice they would give. But, number one, obviously, is coronary heart disease. So we're going to be looking at heart rate, blood pressure, whether or not there's any evidence of, tachycardia or heartbeat problems as in bradycardia. But you're going to be doing more of a focus on coronary status because of the fact that certain medications, particularly the stimulants and especially amphetamine, is going to kick up heart rate and blood pressure. And while the rise is relatively trivial for a typical healthy adult, it's about like walking up 6 steps. It is going to be problematic for somebody who is already in the pathological range, the malignant range, so to speak, of blood pressure, heart rate, and so on. So that certainly needs to be watched more closely in the elderly population. I think the second area that we're going to need to listen for is the growing risk for anxiety linking with adult ADHD over time, so that by the time we get to midlife and late life, about half of the patients may have an anxiety disorder. And anxiety can kind of complicate ADHD management because although you can give a stimulant to a patient with an anxiety disorder, there is evidence to show that a subset of people, it may exacerbate their anxiety. It may impair them cognitively. There's a toxic effect on working memory when you give a stimulant to somebody with anxiety and ADHD that we've seen in a couple of studies. So one would want to be, I think, careful. I would start low, go slow, and monitor anxiety as you're trying the stimulant to be sure that you're not making that worse. Because some patients we know of certainly have quit stimulant therapy because of the increased feeling of tension, anxiety, fear, panic, motor mannerisms, stereotype mannerisms that might come out as a result of stimulant. If it's going to come out, it's going to come out with the amphetamines more than methylphenidate. So I would be listening for that. And I think about a non-stimulant, such as atomoxetine, or even off-label Wellbutrin is often used in adults with comorbid depression and anxiety because of its multiple neurotransmitter effects, including effects on the serotonergic system. So, that to me would be a comorbidity that might come into play with older people where that comorbidity is becoming common. But in general, as Sandra Cooey has shown, she's done some of the best research on ADHD in the elderly and its management. The kinds of treatments we use, including the stimulants, do as well for the elderly in helping them with their ADHD and executive deficits, not to mention, their problems with arousal, alertness, and, focus that come with age as well. So there are too many complications, but to me, it's the coronary risk that you really have to pay attention to. Okay.
Well, I think the hour is up. That
Indeed.
was excellent. Several people have asked how they could get that slide or slides you mentioned. Should they go to your website?
Are you guys going to put that on your website or what? Yeah,
we could do that. Sure.
Okay. Well, feel free to, convert my slides to a PDF or just a black and white handout and have it available for people who were in the seminar or anybody else for that matter.
But there was one slide you mentioned that you said that's basically. Okay.
Yeah. What they can do is I can either send that to you and you can post it, or they can email me. Just Google russellbarkley.org. My website comes up first and send me. And I'll send you the 9 symptoms that are better for adult ADHD than the DSM-5. Yeah.
Okay. That's great. Thanks so much for being here. It really was excellent, Russell.
Okay. You're welcome. All right. Thank you, everybody. Have a good day.
Okay. And thanks for the attendees for joining us. Thanks, everyone, for being here, and have a great day.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com. That's ADDITUDEMAG.com. That's ADDITUDEMAG.com.
tried reading while jogging, cooking, or even juggling flaming torches? Yeah, it doesn't end well. But with audiobooks.com, you can conquer books without the circus act. Dive into over 450,000 titles, including more than 10,000 free ones. Get hooked on a bestseller, find your next obsession, or finally read that classic you've been avoiding since high school. And here's the inside scoop. Sign up today for a free 30-day trial and snag your first 3 audiobooks on the house. Sign up for your free trial at audiobooks.com/podcastfree today. That's audiobooks.com/podcastfree.